our December 9th public call. This is principally our opportunity to vote on the master lists that we have collated over the course of this fall session. Our final sets, veterans, intimate partner violence, and stress. The final sections of those sets, which include codes for goals and interventions. And there'll be updates on other elements as well. Mostly just thank you for joining us today, and thank you for participating in this work over the course of the year. This again is Sarah DeSilvi. I have the honor of being the Director of Clinical Informatics for the Gravity Project, and we're going to get going. Next slide, please. Again, thanks for joining. For anyone who might be new, or just as a reminder, due to the large number of attendees, we usually have upwards of like 100, 120, sometimes 150 folk. We always mute folks upon entry. We ask that you remain muted to avoid background noise. The call is recorded. All recordings are available on the Gravity Confluence for review. As many of you know, I do try to actively participate, actively integrate comments from the chat into the conversation by pausing and reading out loud and ensure that everything is integrated as possible. Please send all comments to everybody so that everyone can see them. Again, if you send them to me, the danger is I will read it out loud. So if it was meant for me in private, it's best to follow up with an email afterwards. We do ask that if there's extensive side conversation within the chat on a topic that's not part of the agenda of the day, we may do a reminder and just ask folks to take that offline, and we're happy to connect different members to each other for out of meeting collaboration. Next slide, please. This is our common antitrust practices slide. Next slide, please. As always, we invite you to officially join the project. I think Evelyn gave the last member tally at 1,300 folk, which is amazing. If you want to check whether or not you've already signed up or others from your org have signed up, you can do that on the Confluence. And then the Confluence remains an incredible reference of everything we've accomplished over our 2 years. It's not a work in progress. We definitely have, we try to make it intelligible, and we're just very grateful for that resource. Again, all the past meetings can be found there. If you have a desire, just scroll through the archives of the Gravity Project. Next slide, please. Huge shout out to our project founders, grantors, and in-kind supporters. The Gravity Project really is the epitome of the many hands make labor light. Although we have our amazing core team of staff members across policy, project management, technology, and terminology, we share work across the collective and with our colleagues such as the American Medical Association and all of our funders. So just as a year-end thank you, I just want to say thank you so much for everyone who's donated resources, both their time and funding to make the work go. Next slide, please. We are continuing to seek additional sponsorship for 2022 operations. I think we're about halfway funded for 2022. It's a way to be recognized as a contributor to the critical national work. And if you have any interest in learning about sponsoring, you can either send a direct email to gravityproject@emyadvisors.net, which is the general email for everything Gravity, or you can visit the Confluence. There is a Gravity Project sponsors page on the Confluence as well. Next slide, please. All right, so I'm going to go through some announcements and then project schedule and overview. We do have our first view into 2022 and what that will look like, and I want to thank you for your patience there. We're going to deep dive into the Veterans, Intimate Partner Violence, and Psychological Stress consensus vote. Those master lists have been stable for quite some time, so we do appreciate the fact that we've tried to filter in comments as able. And then Dan will give a technology update, and then community homework and next steps to close out the meeting. Next slide, please. All right, announcements. All of these announcements are on our announcements page on the Confluence if you want more information. We always try to give a shout out to our sister call, which specifically focuses on the FIRE implementation guide. That's Wednesdays from 3 to 4 Eastern Standard Time. And that's on the HL7 calendar. We also try to give a shout out to any grant opportunities or challenge opportunities that are aligned with the work. You can see our HHS Postpartum Equity and Care Challenge, and the submissions are due on December 17th. And then again, there's many more details to come. And I do want to give a shout out, even though it's not in the announcements, the Connectathon, all of our Connectathons, we do encourage all of our members to come to. Dan will speak more to that, I imagine, when he presents his sections. Next slide, please. We wanted to give a mention to, we promised you we'd do a deep dive into value sets. It really is into what value sets mean for gravity. We did find a time. It's next week from 2 to 3 Eastern Standard Time. It will be recorded. It will be posted on the Confluence. So even if you can't come, you'll be able to review the session. It really is meant to be like a kind of a general user guide to how to access the sets through the National Library of Medicine Value Set Authority Center. Dan's going to give some information regarding how the sets interface with the implementation guide, and then some general topics on how the sets can be used to assist with implementation. This is not a huge deep dive into the technology of value sets with implementation because that's out of scope for what we do with the Gravity Project, but it really just hopes to kind of wet folks' whistle so they can then go on and learn more if they desire to. And then you'll be getting invitation to that through the collective very shortly, if you have not already. Next slide, please. All right, so this is the 2021 roadmap. You all know this very well, right? This is where we've been. And you're going to see some changes as we go forward. You can see that where we are in the beginning of December is the planned sunset for our psychological stress, intimate partner violence, and veteran status domains. Next slide, please. All right, any questions on what we've presented so far? Okay, I'm going to go to a deep dive into a couple, like all things terminology for the next section, and then pass the mic to Dan. Next slide, please. What we try to do at the beginning before I deep dive into kind of ongoing build elements is talk about ongoing consensus data element updates, is talk about build updates. I did want to give a deep dive right now into our winter 2021 ICD-10-CM submission. We've been talking about it a lot. You all will remember we just talked about in September an update to our last year's submission. When we submitted, we asked for comments and letters about some of the topics that were covered in the September 14th and 15th ICD-10 Coordination and Maintenance Committee meeting. In this submission, we make our case for where we want to go forward. The submission itself is available on the Confluence, and we will be soliciting letters of reference. Again, there's the initial letters that happen at this stage really are just to get it heard in March, and so that's the initial push. It's not the same thing as the letters we just gathered, which are letters of comment about the terms as presented. So this is again the submission that is the outgrowth of addressing the domains that we covered in 2021. As we mentioned in September, because of the return of the Z58 series, and as we covered in a special deep dive session on ICD-10, I think like a month ago on a Friday afternoon, because of the return of Z58, which wasn't in ICD-10-CM in the US prior, which it covers problems related to physical environment, we realized we were able to split our material hardship concepts into two different causes. The reason why splitting them into causes is important because this directs interventions, like interventions for individuals who don't have resources in the environment are different than interventions for individuals who cannot afford existing resources. So our ICD-10-CM submission this year asks for two codes. One, again, is through Z58, which is material hardship, inadequate physical environment. You can see the language builds off the parent there, which is problems related to physical environment. And then the same concept we submitted before really is Z59.87, material hardship due to limited financial resources. So really what we're doing is specifying causality and splitting one of the concepts into the problems related to physical environment root, which did not exist when we submitted our submission last year. So we think this is a really significant improvement, and we're looking forward to working with the committee to get this done. Next slide, please. The next concepts are all through our work with intimate partner violence and elder abuse. Again, these are those two interpersonal violence concepts we addressed over the course of this year. Our first request is to create a distinct intimate partner violence subtype. I really want to credit the comments of the collective on this. There was a lot of thought regarding the complexity of having to code adult abuse and child abuse with intimate partner violence concepts. We collectively agreed that a specific subtype for intimate partner violence would be appropriate, and we're respectfully requesting intimate partner violence terms for all of the three subtypes. So intimate partner physical abuse, intimate partner sexual abuse, intimate partner psychological abuse. There will be correlating suspected terms for each of these according to ICD-10-CM. I really want to give a shout out to Sue Bowman and Kathy Gianangelo from AHIMA, who helped us work through all the complexities of the taxonomy with ICD-10-CM in order to get the submission right. We really depend on the wisdom of our experts for everything we do, and we are grateful for our friends at AHIMA. We also are requesting for elder abuse a specific term for the missing type of elder abuse. If you remember when we covered elder abuse, there was financial abuse, there was physical abuse, psychological abuse, sexual abuse, neglect, right? So a critical subtype of elder abuse is missing in the taxonomy as it stands, so we're requesting it. And again, there will be a suspected term as well. All of these terms go along with the CDC elder abuse data surveillance specifications that are agreed upon for national data surveillance. Any questions here? Pretty straightforward. Okay, next slide. Pretty straightforward, but it didn't exist before, which is always like, why? Okay, next slide, please. Yes, hi, Lucy.
Hi, Sarah. Could you just remind us when decisions will be made?
I will, yeah.
These? Thank you.
Yeah, so the first step, again, so these submissions, winter 2021, that were due on the 3rd, will be included, hopefully, in the March IC10 Coordination and Maintenance Committee meeting agenda. There are 2 meetings every year, one in March and one in September. We just had the September one, and we participated in that one. And so we're hoping that this gets heard in March. Even decisions are not made in March. There is a public comment period after that the meeting, and then decisions are made by the committee through public comment and then published to the community after that time. So this December 3rd submission aims for a March meeting with March and April review.
So the soonest that this could actually be approved and incorporated is
a year
late 22 or?
Yeah,
okay.
A year from now.
Great, thanks.
Linda, correct me if I'm wrong, because right, they did do that. It would be a year from now based on that timeline.
It actually, it may be October 2023.
Oh, there we, yeah.
Yeah.
So more than a year from now. There we go. Next slide, please. All right, so the next work that we did is actually interesting. It's kind of a US requirement. So if you look into the US ICD-10-CM codes for perpetrators of violence, there are lots of different options that are all binary. So we, working with our IPV experts from Fenway, and Futures Without Violence and our experts across elder abuse. We are requesting non-binary and gender non-conforming perpetrator terms. We have only requested non-binary and gender non-conforming perpetrator terms that are specifically aligned with the two interpersonal violence concepts we addressed. We did not try to boil the ocean. But in our submission, when you read the text, you can see that we've requested a full review of all terms for alignment with best practice. I do want to state, though, that the level of granularity in ICD-10-CM is not in keeping with international ICD. So it might be something that the committee is willing to engender and undertake, and it might be something that involves some conversation, but certainly aligned with our mission and our objectives. It was a requirement for us to request these terms at this time.
Sarah?
Yes, hi. Oh, look, Sue's right here.
Hello, Sarah. These are children perpetrating maltreatment against a parent?
Well, it's a child perpetrating, yes, in this instance, because it's specifically a child, it would be a parent. Yeah.
Okay.
And this was a critical missing concept from the elder abuse, the CDC data surveillance requirements for elder abuse, right?
Okay.
There was no child concept existing prior.
Okay.
And I do want to thank, look, I gave a shout out to the amazing Sue Bowman, and here she is, helping us with also further granularity about when these terms would possibly be released. Thank you, Sue. And thanks for all your help. Wonderful. Okay, any other questions here? Great, okay, next slide, please. No, Tom, child does not imply the perpetrator is a minor. It establishes a relationship, but not an age. The next thing that we do, Lucy's saying, does gravity submission request expedited, or is this, it does not specifically request expedited. Sometimes the terms are, like for instance, some of our terms were judged to be so important they were expedited with our initial submission. But we don't specifically request that. Many of our colleagues and our stakeholders do, though. The next elements that we asked for were really involving inclusion terms. An inclusion term is a suggested text, basically to assist in proper coding. So what we wanted to make sure of is that our subtypes of social connection were included specifically as inclusion terms in relevant codes. You can see this here. So inadequate social support and lack of social support are inclusion terms under other problems related to social environment. Again, this will assist because these terms will correlate with existing SNOMED terms, and if a person was documenting these terms in a note or in the course of a patient visit or care management, these terms could be appropriately applied. Next slide, please. And the last thing that we're doing is asking for, again, I think we reiterate our desire for a code for military history beyond deployment, basically covering veteran status because the existing history covers deployment. We do this in collaboration with our colleagues at the VA, who wrote, again, a really wonderful letter for the September meeting. And so we asked for personal history of military service, and then we asked for inclusion terms for veterans and served in the armed forces. All right. Anything else on our ICD-10 submission?
Sarah, this is Mike Klinkman. If we can go back 2 slides. I've been thinking about this since I saw the slide. Yes, this one. Having been, I guess, expected to deal with ragbags before in terms of data retrieval, and knowing how big Z60 is likely to be, if we wind up having inadequate social support or lack of emotional support embedded in this ragbag, it may be tough to look for this when we are looking at data for secondary purposes. I imagine you guys have thought about this as part of the strategy about how to get that concept out, but it just strikes me that it may be a tough one to bring out. Oh, and what is a ragbag? That just means it's a code that covers a lot of things that don't on their own seem to be occurring at enough of a frequency to warrant their own code. So several things get put into a bucket, in this case Z60.8.
So I hear you. So we always have to make a case for necessity, but even though they're not specifically called out in ICD, they are specifically called out in SNOMED, right?
So we can do that if the systems people use will include SNOMED terms that would allow us to extract them.
Correct. And some kinds of aggregations, for instance, claims-based analysis would be, possibly it would be obtuse, but with another analysis and exchanging CCDs, it would be more discrete. It depends, and the capacity for our IG definitely uses those US core condition codes that are part of SNOMED CT. So we do try to make, before we are really, really experienced in implementation and have learned initial lessons, we do try to be frugal. And so when concepts directly align with existing terms, we do tend to tuck them in. But we will see if it's sufficient, and if our piloting the implementation says it's not, then we have data actually to move the dial with the IC10 Coordination and Maintenance Committee meeting. But I do want to stress that those terms are discrete within SNOMED.
Fair enough. Thanks.
That sounds like a very political answer, which is not usually my MO. Any other questions here? All right, next slide, please. Okay, so now we're going to go into our amazing vote, our end of year vote. I have to admit, it gets me a little emotional. You guys have done an amazing amount of work over the course of this year. So closing it out is it's just an honor to do this with you all. Next slide, please. All right, so we're getting a first view into what our 2022 early year will look like and what our process and our plan will look like as we go forward. We've been doing this continual push over the course of 2021, and we realize we have a kind of a backlog of coding submissions that we need to do, and we have a lot of education and dissemination work to do. So our new project plan works in 6 months segments, right? So we take 2 months off, build for 4 months, 2 months off. And I say off, I don't mean off. I mean, the terminology team is still working on working with our terminology organizations and, doing disseminating work and just making sure everything's correct. So our initial terms, our initial domains for 2022 really cover concepts of healthcare access. This is a direct response to a comment we made on the ICD-10 Coordination and Maintenance Committee meeting in September, which is why it was elevated. If you all remember, there was a submission for health insurance insecurity. We already had this little kind of like package of like terms in the queue. And given that they're fairly discrete, we're going to mobilize and try to address them early in 2022. And then there'll be a break in the summer, and then we'll work on other domains in the fall of 2022. Any questions as we look at this new plan again? So we'll start a small public call holiday until early February.
Sarah, maybe I'm the only one who sees this, but please interpret for me. It seems to me that for the last couple of years, we've really concentrated on social determinants that patients would feel and potentially talk about. And if nothing is done, there are serious health repercussions. This health literacy, underinsurance, medical cost burden, are those comparable patient experience issues?
I would say yes, right? So as someone who works in for a very short period of time, I am not in a federally qualified health center, right? So I work in a principally fee-for-service clinic. What we know from the literature is, like, if we think about the literature, food insecurity, transportation insecurity, or housing insecurity, insecurity regarding health costs and the constant shifting of funds to pay this bill, pay your insulin, pay food, to pay the rent, That is the daily beat of the low-income rural folk I take care of every day. The same kind of correlations in the literature go along with anxiety, depression, negative health outcomes, not just due to lack of access, but also just due to the stress of the juke and jive, like what it takes to get by. We also know one of our, again, sorry to just kind of go off here, Lucy, but we also base our one of our orientations on the World Health Organization conceptual framework for action on the social determinants of health, which definitely frames the healthcare system as a social determinant itself. So I'm very comfortable saying that these concepts are directly in keeping with our process thus far. And if that's a good enough answer, that I hope it is, maybe it's not, but we can always talk offline too. I have no question that based on the literature and based on experience and practice and based on our orienting conceptual framework that these are really important.
Great.
This is
Thank you
Janice.
for-
I would just chime in that these are very, very important. And even in Washington State, where I live, there's huge, disparities between individuals. They, might be undocumented, and education levels. Health literacy is very disheartening where we're at after so much work in this field. And there's not materials that are understandable for the majority, perhaps a majority of people, for the subject, that they need to know of in specifics. So it's a big area to understand more about. Medical cost burden. Medical bankruptcies were the #1 reason for bankruptcies. I'm not sure now after COVID if that's still the same or not, or it might be worse.
Thank you, Janice, as always. And again, it's a tidy little package, and then we'll get we have 2 other thematic groups to figure out over the course of the next 18 months. So we have this little thematic group, and then we have discrimination and bias and ACEs. And you'll see a comment on that we might actually work on protective factors then as well. And we also have the extension of our initial domains into community level domains. So we have neighborhood safety, food access issues, and access to green space. So all of those terms are still in existence, and there's kind of a reason why this was elevated to the front. But you'll see some of the kind of the parent concepts for some of the more individual level concepts we've covered so far be addressed in the fall 2022 and beyond. All right. Okay. Any other questions? Okay, so this is this kind of the schedule. You can see there's lots of space. I forgot to put the homework in there because the homework's just vote, right? So here we are closing out our goals and interventions, consensus vote for veterans, IPV and stress. There's no public call for 3 meetings in a row while we work on build, submissions, education, dissemination, right? We have created so much, right? It's now our responsibility to assist people in using what we've created and to ensure we kind of clean the slate regarding all the terms we have to submit. We'll reconvene on February 3rd. Our other committee structure carries on. And you might see that there's a special session, and we might say, oh, let's have a special session on this and liberate one of these meetings. But really, the public new term public call build, that's what's taking a brief pause until we reconvene. And then the winter and spring is all about these terms until we head to the end of May. All right, next slide, please. Now we're going to do our voting review. All right, next slide. Next slide, this is about the consensus for social connection. Next slide. All right, veterans, IPV, and stress, goals and interventions, consensus voting. Strap your, put your seatbelts on. There's a lot to cover. Veteran status. I want to give a specific shout out to the VA social work leadership and clinicians within the ACORN project and all of the members of the Veterans Affairs interoperability teams for really leaning in heavily with invested labor and heart and care over the course of the last months to get this right. We would simply not have done this as well without them. Very, very grateful for John Bolster and for Charles, who helped kind of be the handmaidens in that collaboration. So thank you so much. Very, very grateful. So there are some updates within goals. So we have kept honorable discharge and military discharge upgrade. You remember these. We established a general goal of establish eligibility for Veteran Affairs benefits. And because of, you'll see in our terms, care to use terminology that aligns with policy responsibilities and divisions within the VA, right? The VA is massive. There are many, many different divisions within it. And so in order to align and collaborate with CARE, so to have community partners be able to collaborate with the VA and vice versa, because this is kind of the primary use case that we imagine from interoperability within the VA, in order to document care within community settings, we really had to be careful to have our terms align with the structure of the VA itself. So there's general eligibility, and then you can see there's specific eligibility for burial and memorial benefits, because this might be a goal as well, and it's established separately. So honorable discharge, military discharge upgrade, eligibility for Veterans Affairs benefits, and then specific eligibility for burial and memorial benefits. Thanks, Charles. Grateful for you. So this again is just to align with the structure of the VA and ensure that as we're sharing information across different settings, we are communicating intelligently. In general, with all of the VA terms, general concepts within our HIT terminology link and map to massive amounts of specifications and details within the VA coding. It's very akin to our work with 211LA, where we're speaking in general concepts. There's incredible amount of granularity once you get into the VA system, but at least we'll be able to speak in kind, right? So I'll say this, you'll say that, we'll be able to speak in kind, which is the intent of data standardization. Next slide, please. We have a general approach. So first of all, to again include all primary resources, hotline directories, and in critical professions such as Veteran Services Officer, in VA social work, again to allow the communication and coordination between community settings. As I mentioned, we have naming conventions for all the official programs, and again, we really appreciate some public comments here. Because again, this is a test. We're focusing first on federal VA programs with the intent that if there are any other programs that happen in different settings, such as local or state, we can pair the specific need with this concept of hopefully that VA ICD-10 CM concept or the correlating served in the armed forces concept within SNOMED CT, and then develop a use case for further refinement in time. And again, we did create these parent concepts that allow this group of programs to enable mapping from the VA to community care, like I said. So there is this general concept in HIT that then maps to a general concept within the VA, under which within the VA leads to all kinds of different subtypes. Next slide, please. You can see that the Veterans Interventions Program list has gotten quite tidy and organized since we last presented it to you. So again, these are those general parent concepts that map to massive amounts of programs that will allow care coordination across community care settings into the VA and vice versa. So social work care can be shared across different settings, or discharge management. Again, incredibly grateful for the leadership of the VA social work team and the VA clinicians that leaned into this work and just put lots of hours into it to make it right. Any thoughts here? And all of these are defined. If you look at the master list, every single one of these programs has a clear definition and a link and a reference. So if anybody wanted to know more, that is all there for you.
Sarah, forgive that I know so little about this, but just a point of information. Are all of these interventions available at any VA clinical site?
Yeah, so these are federal level interventions. Yeah. And the thing we learned again, and part of what I think is so amazing about this project is I am a community care provider who, because I'm rural, I do lots of primary care for veterans. I did not know about the capacity of the VA social work team to assist me and my patients in getting these services until I did this project, right? So that's partly why we built the primacy of referring to the VA social work program, so all the breadth of these different options can be revealed to the veteran in hand.
Wow. Thank you. You're not the only one who didn't know about this, and you should have known, but
I know I should have
the
known.
rest of
Now I
us
do. Yeah.
who,
And this is
who aren't clinicians or vets or related to vets probably have no idea. So this is really quite impressive. Thank you.
Yeah, and you can see, so depending on the rurality of the place, like the closest VA medical center might be a bit away, but we also have facilities locators in there, and then the navigators, the veteran services officers. So these are all ways to access care for veterans, regardless of where you're practicing. And again, we hope this is one of those like really tangible outcomes of the Gravity Project. We really hope that this kind of resource, the value set that will eventually be in VSAC, really enables enhanced care coordination for people that need it. Wonderful. Okay, next slide, please. I think that was it. Any questions on veterans? Again, I just really can't say thanks enough. Oh, there are also regional, state, and local satellite resources. Correct. Yeah. So Brian, I do want to state that we had a few comments asking about specific regional, state, and local terminology build. And again, that's what one of the bullets, like due to the extensive amount of initial federal build, understanding that we can come back at any time. So we're initially building the federal concepts and then hoping that to basically just kind of test how sufficient this is and then do further refinement on the veterans set regarding state and regional and local terms in time.
Sarah, one quick question on the veteran goals.
Correct.
That I think you can.
Yeah.
The few veteran goals that were listed, which were related to establish eligibility, those goals are not interventions. They're going to be findings that can be used as a goal, so that it'll be eligible for veterans better.
Correct.
Yeah. Okay. Yeah. Yep. Yes. Just checking. Yep.
Yeah. No, this is when and I feel like there's always a Monique filter that happens in my head after. Based on Monique's brilliance within SNOMED, sometimes things get stated and then I realize how they'll have to be subtly changed in order to fit into SNOMED. But as always, the concept's represented here and it will have to be changed slightly to fit into the taxonomy. And Monique, sorry we didn't get to this one before I put it on the slide. But
yeah, no problem. They're just going to be findings, not interventions, though, is the
correct.
thing you've confirmed. Yep. Thank you.
Correct. Yes. Yeah. All right. Okay. So any other questions? Wonderful, Brian. All right, on to intimate partner violence. Next slide. Again, a specific and very deep, Emma, I think your mic is on. Thank you. Again, thank you to our subject matter experts, Chris Grasso from Family Health and Lisa James from Futures Without Violence. They've just been a delight, honestly. Just working very carefully with them over the course of the last year. They're the kind of folks you miss when you don't talk to them. So thank you so much. And I do want to specifically call out that Chris is helping us form a Fenway letter in response to the non-binary options within ICD-10-CM. So grateful for her help there. Chris is always helpful. Like, lovely to work with. Lisa is too. Just fantastic people. Next slide, please. So here are some updates. Again, this is kind of, we have the luck of presenting these to you here after they have gone through some of the amazing mind of Monique Van Berghem, our colleague at the AMA, who's so smart in these things. So this is some of the adaptations that we've made within the goal statements, but the goals remain. You can see the concepts are still the same. So we have safety from no known risk of the adequate social support and social connection terms that came over, limited perpetrator access to victim of abuse, which will be across all of the different interpersonal violence terms. And then we changed slightly our mitigated terms in order to, again, to reflect the requirements of SNOMED. You can see the concept is still here, so intimate partner violence, mitigation measures in place. We really kind of liked this. This is what we came across with, came up with working with SNOMED CT and our IPV SMEs, and Monique and Linda and Katya from the terminology team and Asha, because mitigation is an ongoing process in these instances. So again, no changes to the intent of the terms, some slight tweaks in order to fit better within SNOMED CT, and these are the IPV goals as they are getting submitted. Again, for getting voted on, and then they will be, we will go forward with them as we, with SNOMED CT. All right, next slide, please. I do want to give an update. So one of the things that came out of our IPV work was a lot of breadth and thought regarding protective factor concepts. We've talked about protective factors and the intersection of protective factors and goals throughout our work. The work with intimate partner violence experts really elevated some of the primacy, the really necessary protective factors that are used in interpersonal violence, such as cultural identity, cultural connectedness, spirituality, and self-efficacy. We do not have the technical experts to address these terms well, and many of them intersect very importantly as the balance to some of the racism, discrimination, and bias concepts that we're discussing likely in fall 2022. And so just to do these concepts justice, we're going to hold on them until we assemble the TEP. And so we can do it, we can gather the correct experts to do this work well. For instance, cultural connectedness is a really, really critical term in American Indian and First Nations strength and work. And so it just seems really important to make sure that we have the right folk to do this well. Any questions regarding this hold? Again, this is one of those moments where we realize we really need different people at the table to do it right.
Sarah, I'm wondering about extended family, whether extended family is ever a protective factor or almost never, or only with some kinds of interventions which may be less frequent than others.
You know, Lucy, that's actually a really interesting thought. There's a, you know, in our research in getting ready for this work, there was a lot of lovely literature regarding elements of protective factors. The specific SAMHSA paper regarding cultural connectedness and American Indian and First Nations communities that was really lovely. And it actually talked about the intersection between our social connection domain, right? And the balance of connectedness that happens there with, social support and a sense of, fulfilling relationships, and how familial and non-familial connectedness are important, and then cultural connectedness as a part of that, and then spiritual connectedness as well. So all I can say is familial and non-familial connectedness are generally under the umbrella of the social connection domain we've already covered. But there's these gaps that we haven't covered yet, like cultural and spirituality. And so we will address those ever so shortly. And then, Carrie, this is true because we've always talked about our goal statements, some of our goal statements being able to function as protective factors as well, right? So less than a high school education is, it might be a problem, but having that might be an asset, right, or a protective factor. So as we do this work in protective factors, we'll be thinking more about the kind of again, that scale slide that I showed at the beginning, not the beginning, but like last meeting and the meeting before, that shows how protective factors prevent risk and social risks cause risk and how they intersect. Yes.
I have a related question, Sarah. This is Mike again, about whether we've reached out or looked in detail at what WHO has done with ICF, because there was conversation about a piece of that classification being protective factors, and I don't know how that wound up working out.
I actually have, yeah, and that
Good.
actually ties very closely in to work that's happening within social connections space. So that
Perfect.
is 100% on our radar.
Good.
Yeah. Okay. I think we're good here.
This,
Um,
thank you
yes,
for this conversation. So much of what we do, the minute we really start thinking deeply about it, turns out to overlap with so much else that we do.
correct.
So
Yeah.
maybe as we become better educated, better informed, more sophisticated, and more understanding of this interconnectedness, we could be talking about whether what we've already done is sufficient
Correct. Yeah.
for a particular domain that we're now concentrating on, and see what the consensus is, because maybe where we already talked about it wasn't nuanced enough, and we
Yeah.
need to bring it back, and maybe even label it differently, but maybe we need to bring it back because it is so relevant for another domain that we're now talking about.
And that happens, I guess, this is kind of where I wish I could take some of you with us sometimes in like, because in a given week, it's like it was for the last months, it was psychological stress on Tuesday evening, social connection on Thursday evening, elder abuse on Friday morning, and then intimate partner violence on Friday morning, and then veterans at lunch, right?
Yeah.
So that relationship between all of these and how one informs the other, and like bringing some subject matters into each other's meetings, right? That all happens, and I do want to state that we imagine this process as iterative. Our process has these feedback loops that come back and make sure we're getting it right. Some of that depends on testing and implementation and piloting, and some of it depends on our own, like we're doing new work here, right? I've been very aware that this is very, like it's a pattern that we're making together. So within that awareness, also, I want to state that we could, Lucy, 100% realize that we might have not done it as well as we want to now that we're further along our sophistication, and we can loop back on that count as well. And I definitely hold space for that. I think it might be necessary.
That's great. It's almost a philosophy course
Oh,
at times.
yeah.
The interconnectedness of everything and how it impacts health status. I
Well,
mean,
these are
it's really amazing that we've been able to disaggregate and concentrate and focus as much as we have. It's just extraordinary.
Well, yeah, because the truth is we're talking about people.
Hmm.
We're not disaggregated, right?
Right.
Yeah. All right. Okay. Next slide. No changes here to common programs with elder abuse, IPV interventions. Again, these are all the definitions of the programs. Next slide. There's only one new addition here, and again, Lucy, this is a credit to you, but this is what basically building off of this concept. So it was in our psychological stress group that Dr. Prather recognized a need for faith-based community programs. It was socialized across all the different groups and then integrated. It was a notable omission, and so it's there now. Um, Next slide. All right, so we covered veterans, we covered intimate partner violence. We're on to psychological stress, which is fairly tidy, and then segueing to the vote, and then I pass the mic over to Dan. Next slide, please. Dr. Prather, so kind. He's one. He's the figurehead connected to the whole UCSF stress measurement network. So I do want to thank Dr. Prather for he was almost the care coordinator for the whole work, because he was the one who showed up every single week and then would do field work on his own to make sure all the insight of Dr. Adler and that whole set of wise ones of the Stress Measurement Network was included. Thank you, Dr. Prather. Next slide, please. There are no changes to the goal statements with psychological stress. They are as they have been. And there will probably be some updates based on some agreements with form that we have with SNOMED CT. Again, we're shaping our structure of our terms as we go and creating patterns with SNOMED CT that once we establish them, we'll just start replicating them across other domains. So some of these elements you can see stress mitigated will likely be changed, representing the same concept, but the approach will follow what we did with intimate partner violence. Next slide, please. No changes to common programs of social connection. Again, you can see this was a shared work across those two domains. Next slide. And then here we are, this new program of social connection. Next slide, please. And that is the summary statement of the updates with veterans, intimate partner violence, and psychological stress. And we've had a lovely conversation regarding work that's to come. And so next slide. We are on to voting. Again, a reminder that the vote starts now and carries through till tomorrow evening, Eastern Standard Time at 5, I believe it's on the next slide. These are the ways you can vote. A yes vote does not necessarily mean the deliverable is the ideal one, but it's better to move forward than block the deliverable. Yes with comment requires the comment be emailed within the week. So if this is a yes and you have a thought process on that, we have these sets have been stable for a very, very long time. So we've had lots of comments up until now. So we'll see if that changes the amount of comments we receive at the vote. You just need to email comments to gravityproject@emiadvisors.net by 12/16. A formal objection, again, has to include a comment, and it also has to include a path to addressing the objection in a way that meets the concerns of other members of the project. So if the better part of folks are in agreement with the approach, it has to integrate those thoughts because we are a consensus project and we've been working together now on these sets for the course of the last months. Again, the email needs to be sent to gravityproject@emiadvisors.net by 12/16. An abstention is just a member declining to vote. Next slide, please.
Sarah, is it too much to ask for the project to keep track of whether each individual attending has voted or not? I'm sorry that I can't keep track of this.
We do track attendance and voting.
So you can you ping, could it become SOP to ping people 48 hours before a deadline if you haven't voted yet, or something to that effect, Evelyn?
We have instituted, you can see we sent out some reminder emails ahead of the vote. Because the vote period only lasts 24 hours, it'd be hard to do that kind of reminder, but we sent 2 different emails regarding the vote and absentee ballots. And Lucy, we can figure this out if there's something that you need from us, because we always try to respond to members, but just let us know. We want to make it as user-friendly as possible, and we want as many members to vote as possible. It was your idea in the beginning to do the absentee ballot thing, and that's part of the methodology now on Tuesdays. I think Sarah B sends out that.
Okay, thank you.
But just let us know if we need to do a better job. Like, did you get the absentee ballot email?
I'm pretty sure, but I hope I'm not the only one of the 85 participants here feeling like a prompt, if I haven't voted, would be helpful.
We will see if we can figure out how to do that.
If I don't get a prompt, I will assume that I've done my job. Thank you.
Yeah, we will figure out a way. We'll loop back, Lucy, and see if we can figure out a way to address your concern. We do have over 1,300 members, but we appreciate the fact that you are a regular voter, and we want to make sure that we eliminate any barriers. We're grateful for you. All right, so the consensus, the Google poll for that one link, again, if you're getting there from WebEx, you might have to hit it twice. That will take you to the sheet which does all of the voting for these 3 sets. And then don't forget to send your comments to gravityproject@emiadvisors.net. Are folks ready? And if you want us to specifically send you the poll, you can just email gravityproject@emiadvisors.net. Are we okay to move on? Okay, next slide, please. This was just my little synopsis of all the different subject matter experts who helped us over the course of 2021. Many of them have just become dear friends. So incredibly grateful for this collective. And there's all kinds of schemes. There's don't leave us, Sarah, Katya, and Linda. We want to write a paper. We want to help on this. We want to keep in contact. It's just a lovely, it's a lovely collective of subject matter experts, and we're just incredibly grateful. Tom has a good idea. We're sending a reminder to everyone 4 to 6 hours prior to closing of voting. That's an idea. It is within listserv. We should be able to do that. Again, thanks, all SMEs, and thank you, everybody. Next slide, please. I just want to thank the collective. I mean, I said this on the last slide, but there's just what we accomplished in 2021 is simply remarkable, and it's my honor to do it with you all. And I look forward to future work in 2022. Thank you so much. And I believe we are passing the mic off to Dan. I've consumed almost the whole meeting, Dan. We still have a little bit, though. It is an hour and a half, thankfully. Next slide. Thank you, Dan. Thanks for your patience.
No worries, no worries. We hope you all can hang on for a few minutes longer. I'd like to share with you a couple of updates on the technology side. If you go to the next slide, I'll remind folks in the last few sessions, we've been building up our repertoire of tech lingo, and you can revisit some of our definitions. We're going to spend a little bit of time on this last one again, talking about the upcoming Fire Connect-a-thon and kind of what's involved with that a little bit, in the hopes that we have robust participation from the community of implementers. On the next slide, I'll share kind of the two big highlights or requests from you for those of you who have interest in the exchange standard part that sort of puts the terminology work into systems. Two important opportunities. The first is the participation in the HL7 ballot cycle, which in order to do that, you don't have to be a member, though there is a fee if you're not, to officially vote and comment on the version 2 spec. The sign up for that closes today, so encourage folks to do that if they haven't. And then the second is participation in the Connect-a-thon, the testing event where systems can walk through and try to connect and exchange information with each other in a sandbox or so testing environment. That registration is available just through December 13th. So we encourage folks to participate in that. Now, on the next slide, I want to share with you the great news that our updated version, STU2, of the Fire Implementation Guide has been approved by the Fire Management Group to go ahead for the ballot. Humongous thanks to the technical team, Bob and Monique in particular, with Corey and Lloyd and others contributing so much to that. We're really happy with the enhancements that we've been able to make to this. Here you see on the screen the sort of landing page of what that looks like. And there's a link down at the bottom for folks who want to dig in a little bit more. What I wanted to cover with you today was just a couple of recap highlights of the main features of things that have changed from the initial version that was published earlier this year. On the next slide, I'll talk about the first one of those. So the main one main set of activities was enhancing the representation of a few workflows that were started and sketched out in the first version, but not totally completed. That includes the opportunity for a patient or caregiver-facing application to interact with the other system components, as well as the use of an application by a community or social care organization to interact with another system's server and techniques for apps like that to be able to synchronize across multiple referral sources. The next slide shares the other big kind of advancement, which is really building on the foundational work of the terminology team and the coding work. This is an approach to more closely connect the collections of terms for various social determinants domains to the structural elements in the implementation guide. We've been working hand in hand with the team at HL7 that works on the US core FHIR specification, which is kind of the baseline specification that many electronic health record system vendors are working towards to ensure that when it comes to social determinants of health content, that is the assessments, the goals, the interventions, the condition or diagnosis codes, et cetera, that the approach in our implementation guide is completely and fully aligned with the approach that US Core has. It's just that our implementation guide has some extra features, including all of those workflows that I just described. But in order to do that, we had to be able to point the FHIR specification to computable definitions of the collections of terms for those elements. And that, of course, is the great work of the terminology team that we are leveraging. On the next slide, I am trying to give you a visual of what I mean by what I was just talking about. I'll see if it works or not, or you can tell me if it works or not. To use one example, the condition resource or structure is the way in which a diagnosis or a problem item is represented. One of the key data elements in that structure is the code for representing the condition. And in our implementation guide, that data element is linked to these two value sets, or pointed to. Structurally, it points to the US core condition value set, which essentially contains relevant ICD-10 codes and SNOMED codes across all kinds of conditions. But we also link to and point to the more specific SDOH conditions value set, which is the one developed by the Gravity terminology team. That value set is kind of a subset of the overall US core condition code 1, which is sort of the upper bound. But inside of the SDOH specific one are pointers to more specific collections for each SDOH domain. So there's a food insecurity ICD-10 value set, a food insecurity SNOMED value set, et cetera. And all of those are sort of pulled together into one parent grouper set. And it's in this way that our sort of structural profile for representing a condition can point to those more specific things. And our guide is doing it in exactly the same way as US Core is doing it, so that we're attempting to make it totally compatible for health IT vendors. So that hopefully gives some visual sense to how these things connect together. On the next slide, I'll mention the last sort of key feature or enhancement to the implementation guide, which is a draft specification, but one that we're really hoping we get some feedback and input on, which is a way to report race and ethnicity in a slightly more refined approach than is currently available. Now, all of this is consistent with the OMB and CDC standards for reporting this, but the current approach in US Core uses an extension mechanism on the patient resource. So it's kind of like an extra data element or field attached to the demographic part of the patient resource. This particular approach doesn't give much opportunity for the metadata or provenance support to help track when and how or who updates that. And so based on input from our user community, And the use cases that they've observed and recommended to us, we're piloting a new approach that uses the more robust observation structure, which is basically a structure that has an element for reporting the observation and one for the value, and there's some other metadata around the timing and who it's about and who collected it and the methodology and so forth. And in this way, we'd be able to more fully exchange race and ethnicity about patients, related persons, and providers, as well as to be able to represent the sort of source and method by which that information was obtained and or may change over time. So we've had a lot of discussion about this kind of across the Gravity work streams and with others at the HL7 community, but we're really hoping that implementer feedback comes in about whether and if this approach is a good one. And if it is successful or deemed to be successful, then it may supersede the current extension-based approach. I do recognize, sorry, I was not totally tracking the chat, but Mike, you asked a question, I think perhaps about the previous slide, about would this allow non-healthcare vendors to adopt the simpler SDOH value sets.
Yeah, that was pretty cryptic, Dan, but yeah, the idea is that maybe a small CBO can adopt the value sets specific to their domains or a set of them, so they don't have to implement the full bore stuff. It may just make it easier to start to work on the community side to do some of this stuff. If I'm reading this correctly.
That is, yes. So that is the, I'll say the elegance and the beauty, if you're a nerd like me or Sarah, of the sort of architecture of this approach, is that from the specification side and the testing side, we can point to that parent level one, but because it contains fully defined subsections for a particular purpose, such as a more tailored system, you can really just focus in on the smaller pieces that are of relevance to you. And yet know that if you have that smaller focus and drill down, say just to housing and security coding, for example, in a particular element, that you're fully compliant with the overall structure. So it really does support that kind of more zoomed in approach. Thanks for the question. All right. So with that, that's the great news about the implementation guide. Thanks to the team for that. And last, I wanted to cover just a few things about the Connect-a-thon. A reminder, this is coming up in January, and sign up is happening now. On the next slide, I've put our recap of what a Connect-a-thon is about. And I see a question here from Ken about, is there an idea of when, from an adoption perspective, this might happen, of moving from extensions to observations? That is a great question. Firstly, for a majority of contexts, the U.S. core profiles are really kind of the baseline to which people are orienting. And our thought is we're going to test this with some use cases, and if successful, it may sort of supersede or replace the current approach. That would take some time, probably at least one round of ballot and comments and subsequent publication, and then later towards the implementation side. We're also thinking about and have some comments around the alignments or kind of transition between the two, and what to do if you have both of them, because as it stands, in order to have one, in order to have an observation, you have to point to a subject or a person resource, and of course we want the information to be consistent. So there's some discussion about how best to do that, but I think it's yet to be determined. Is maybe the shortest answer. So about the upcoming Connect-a-thon, this is a place where we try to test and connect systems with the goal of learning whether the specifications themselves are clear enough to be consistently interpreted. On the next slide, I illustrate how the track for gravity within this event offers the opportunity for a variety of different system actors who could participate with us, meaning depending on your organization, your orientation, your ecosystem, you may have some or one of these, or maybe be interfacing with multiple of them. But the folks who could contribute and participate in the testing might have, say, a clinician-facing information system like an electronic health record, or an intermediary platform such as a coordination platform or health information exchange. You might be interfacing between clinical care organizations and social care organizations. You could have, say, a case management system that serves social care organizations, or applications that collect information from folks via surveys or forms, payer health information systems, or other kinds of patient-facing applications. All have a possibility for participating in the exchange. On the next slide, I try to visually illustrate the potentially testable kinds of system interactions that the implementation guide supports. This is a riff on some of the diagrams, visualizations you might have seen before, where the orange lines indicate a situation where the interaction or system information exchange happens with an application that talks to another server. It doesn't have sort of server-like capabilities natively. It just is sort of reading and interacting with another server. Whereas the blue lines indicate connection points between systems where it's kind of server to server talking to each other, where there's read-write capabilities happening sort of on both sides. And so in these interactions, you see the possibility of actors being, say, a public health or other government entity IT system, a clinical site system, a payer system, a application, either a web or a mobile app that a patient might use, the opportunity for a coordination platform to connect, between, say, a clinical provider and a network of community-based organizations. And then over on the right-hand side of this diagram, you see kind of two instances of community-based organizations, one who might be using an app that talks to one of these other components, and one who maybe has a case management system that has more advanced API functionality built into it. I show this diagram to kind of illustrate the breadth of the ecosystem that we're trying to design for, recognizing that there's not one single pathway through which all of this information has to share, and there's a lot of variation across geographies in terms of how these things work. But in the next couple of slides, what I'd like to describe is the possible workflows using this same diagram, just to kind of zoom in a little bit to help you see what might work, or maybe this resonates with sort of where you sit and the kind of interaction that you might like to see. So one workflow option we label as a direct referral. This is the case where a referral source communicates with a referral receiver using FHIR APIs, application programming interfaces. And here, there's only two actors that are communicating via FHIR read-write APIs. And this could happen in one of two cases. In one case where the receiver is the actual referral performer, such as the case where a clinical provider might have an interaction with a system at a community-based or social care organization. But there might also be a case where there's only two actors that communicate with the FHIR read-write APIs, where there's an intermediary. So the clinical site might interact in a read-write way with a coordination platform, who might have the ability to make available information via an app. that could be another way that would fit this sort of direct referral sort of scenario. So the community-based organization might be using an app that's talking to the IT system on the coordination platform. On the next slide, we have a slight variation of that workflow, which we call direct referral light. So basically, it's kind of the same situation, except it's where the referral receiver does not have FHIR write capabilities. They'd be using an application and is not going through an intermediary. So this could be a scenario where a clinical site EHR system, for example, might open its communication ports to an application that a community-based organization could be. So Rita, I see your question there. Could the individual patient client also be a referral source or a self-referral? In life, in the real world, of course, yes. We have not designed the implementation guide to fully cover that scenario just yet. I'll give, in maybe 2 slides, I'll show the kinds of patient or client individual interactions that we have described, but we haven't quite gotten to this. Can you give an example of the application the CBO might use? Yes. Oh.
And I would like to second what Rita has asked you, because the fact is that for many community resources or community-based resources, a competent patient or a patient who is not comatose is given a list to self-refer. And this is so common, such a prevalent use case, that I just want to underline how important it is to ultimately get to that.
Yes, thank you for that. And when we get there, I'll show how some sliver of that scenario is described, but probably not completely. And so thank you for that. And there's a little bit more work to do there. So an example of the application, I think one example would be what we have in the reference implementation, and I don't have visuals of that now, but you can imagine that it is an application that can retrieve referrals from, say, directly from, say, a collection of clinical providers or via a coordination platform, and then have functionality to sort of manage the status of those referrals, to sort of provide updates back to the referral source on whether they have been completed or are in progress, and so forth. So that would be an example of some such application. On the next slide, I believe, is the third sort of primary referral pathway, and we call this the indirect referral. Indirect in the sense that there's 2 separate kinds of interactions where a referral source, and again, I'm just using sort of the example here of a clinical site. It could be, for example, care management functions within a payer entity, equally true. But a referral source interacts with a coordination platform by making a service request, and then that platform creates another sort of request inside of the referral performer's information system. So kind of a chain of commands or 2-step process whereby if and when the service is delivered and completed, in order to sort of fully close the loop, it would have to go back to 2 steps. First back to the platform and then back to the originating referral source. And this workflow is described in the IG. On the next slide is the one that I was referring to in the questions, where we describe the collection of possible patient interactions in this model. So if you could move to the next slide, that'd be great. Fantastic. And I'm not sure, maybe you all were seeing it before me. My internet has been slow. So here is the sort of collection of interactions that a patient app could provide. This is not like a requirement, but we want to describe possibilities. So, over on the right, you can see in the top part, the snapshot sort of the patient with this app potentially being able to connect to multiple different sources that provide different parts of these workflows. But the main sort of features might be, for example, to receive a copy of their request that is sent, say, from a clinical provider side to a social care organization. A copy of that can be read by the patient app. The scenario where we were talking about sort of self-referrals, we have architected and described specs to allow contact information for the service provider to be shared directly with the patient, with the corresponding information to say that that it's sort of up to the patient to contact that service provider. But what the app could provide is that sort of list or that contact information. So that part of it is described. There's also the possibility that a patient-facing app could cancel the service request or indicate the reason, for example, through some short questionnaire. Or other kinds of questionnaires can be enabled to collect information from the patient, for example, risk assessments or potentially service qualifications. We haven't outlined, requirements for what those would be. But we have enabled the functionality to present a questionnaire to a patient application in this case. And then also the ability to receive information about the available services, which, traditionally and probably conventionally is something like just sort of a PDF brochure, but the sort of direction or communication of that to the patient, we've outlined how that could happen via the app. And then lastly, there's some opportunity for the app to be able to help close the loop on services delivered, for example, via feedback forms that might be presented or queued up for the patient to complete, who could describe, for example, whether the services met their need, et cetera. So those are the kinds of interactions. Again, this is not sort of required, but the reference implementation patient software that we've been working on has some of this functionality in it, and is what we're hoping to be able to test further as we go. So with that, I will just move to the last slide, which is again an open invitation for your feedback on these technical specs. I've tried to share with you, a high level of these different possible workflows, and certainly encourage anyone with interest to dig in, to join our weekly meetings, and to provide detailed feedback, whatever it may be. With that, thank you very much, and I'll pass the mic back, I think, to Sarah to bring us home.
It's true. Dan, I was humbly trying to play your chat linker, which I did not do a very good job. But I do want to thank, I know I was racing over to the Confluence and trying to post links to the reference implementation. So I do want to state that the Confluence is not only a wealth of information regarding all of the terminology built, including every single master list, all like definitions of key programs and screening tool examples. It also contains all of the work that Dan is speaking to. So I really want to thank the EMI team who linked to the Gravity's reference implementation and the correct app, because I was clicking and linking things as you were speaking. And Dan, thank you for the really helpful educational materials regarding the IG. I feel like you do such an excellent job in making really complex things seem simpler. So thank you so much. I do want to actively encourage, and I said this in the chat, all of us to join as able to join the Connectathon, because it really is the balance. This is what I said in the chat, and it's 100% true. The collective work we do here to shape terms right? All of our stakeholder engagement, making sure we have all the different voices. The correlate of that is the Connect-a-thon, right? So if we can get different stakeholders, different bodies, different perspectives at the Connect-a-thon to test this work, that it'll be a better product in the end. So please do sign up for the Connect-a-thon. The link is way up in the top of the chat, and then I tried to link it again and just snag it and drop it down. So really encouraging everybody to attend, and Dan, thank you for your leadership. Next slide, please. Next slide. So this is where I built in a little round of applause. I just want to have a moment to thank all of you for the amazing work we've accomplished this year. Everything from like incredible consensus data sets to our VSAC value sets, our closing out our last 3 domains here today with a consensus vote, our inclusion in USCDI, alignment with US Core, the balloting for the IG. I mean, like literally 2021, although the world is incredibly complex out there, the work of the Gravity Project this year has just been immense, and none of it would be possible without the collective. Like, we are a group. There is no one individual that carries this labor. It is not one committee that is to be credited. It is all of you, and we are just so grateful to be here with you, and grateful to close out December of 2021 really just on a heap of accomplishments. So just a moment of applause to everybody. Yay! Excellent work. The only homework is to catch up on needed materials and recordings on Gravity Project materials as needed and submit those votes, right? We just got to close out these last 3 sets. We have an ever so brief break over the holiday, right? So December sunsets. We have January for break for the public call. Again, the work of the terminology team continues as we try to make sure that all the terms that we've collectively agreed on get built into code. We'll curate value sets as able, and then we'll reconvene in February to kick off our new domains. Thank you so much, everybody. Really just the best work, and so grateful for everybody.
Thank you, Sarah, without which this never would have happened.
Oh, you're very sweet. We collectively, this is us. It's like,
yeah, I know, but collectives require leadership, and you've been remarkable.
Yeah.
Thank you so much. Thank you so much. So the rural person in me will say it's just one big old barn raising. You can tell I'm from Vermont. Thank you. We'll see you soon. If you miss us horribly, send us an email because we will miss you. And we'll see you in February.
Thank you, everyone.
And don't forget to go to the Connect-a-thon. Please, Terminology Director says, please go to the Connect-a-thon and sign up. And I just will be very grateful. Okay, thank you. Bye.
Happy New Year.
Happy New Year.